And welcome back, future nurses. Now I'd like to talk to you about tuberculosis. So tuberculosis is a lower respiratory infection that's caused by Mycobacterium. Tuberculosis if you like to watch Western movies, I would recommend the movie Tombstone. In this movie, Val Kilmer plays Doc Holliday. Doc Holliday apparently was a dentist. He contracted tuberculosis from his dental practice. And Kilmer does a brilliant job in that movie of depicting someone with advanced tuberculosis. So you can get a good idea of the toll tuberculosis takes on an individual by watching that movie. So it's estimated that some 1.7 billion people, yeah, you read that right, billion with a B. So that's about 25% of the world population. Are estimated to be infected with tuberculosis. The global incidence of tuberculosis, which I will abbreviate TB, it peaked around 2003, and then it appears to be declining. Slowly, I must add. So according to the WHO, and these numbers come from 2018, in 2018 there were about 10 million individuals who became sick with TB, so new cases. And in 2018 there's a confirmed 1.5 million globally who died from tuberculosis. It's worth saying that the number of cases of tuberculosis vary substantially throughout the world. The highest rates are between 100 to 100,000 or even higher, are observed in sub-Saharan Africa. Also India. And then there are various southeast islands. And those southeast islands in Asia and Micronesia. So southeast islands. Intermediate rates occur in China, Central and South America, Eastern Europe, parts of the former Soviet Union are hotbeds of tuberculosis. Northern Africa, and then low rates, which low rates would be, so intermediate rates would be 26 to 100 cases per 100,000 or so. I got this wrong. Per. P-E-R. Per. There. And then low cases, so in the U.S. and Canada, Western Europe, Japan, Australia, those places, the low case numbers, 25 per 100,000. So major contributors to surging tuberculosis or poverty, because with poverty you have poor hygiene, and poor hygiene is linked to tuberculosis. The other biggie is HIV, and then drug resistance. And 95% of TB cases occur in developing countries. So if any of you do any international medicine, you will certainly run into people with tuberculosis. So tuberculosis is acquired through the process of inhalation. And it's carried by droplets. This is an extremely infectious organism. It takes only one organism potentially to infect you. In fact, it's clear that organisms are also shed by talking. So you could literally be having a casual conversation with someone and get infected. You don't have to have them cough on you. The organism is also remarkably resistant to desiccation, I think I spelled desiccation right. That one always trips me up. Because of that, in American history, there was the disgusting habit of the cuspidor. We might know by the colloquial term, the spittoon, which was for expectorating while you were chewing tobacco. And the organism is very resistant to desiccation, and it would then, when the cuspidor was disturbed, would come up in droplets and aerosols and would infect people. Fortunately, this disgusting habit has been prohibited, and so that has contributed to the decrease in tuberculosis cases in the United States. The other biggie that has dropped tuberculosis cases in the U.S. and developing countries is the pasteurization of milk, because the organism is associated with cattle and it can be shed into the milk. Pasteurization of milk kills the organism very effectively, and that has led to drops in TB cases. Now, you might say, I grew up on a farm. We used to drink raw milk, and we were fine. Let me just say to you, you were lucky. Consuming raw milk is a very bad idea from a public health standpoint. Your cows might be healthy, But a healthy cow can shed salmonella. A healthy cow can still shed other types of microorganisms. If you're drinking raw milk, that's a very bad idea. My wife grew up in a family whose dad was a milker. She used to drink raw milk as a kid. They were fine. They were healthy. That's simply due to the fact that veterinary medicine in the U.S. is very advanced. And also, they were lucky. Many people died from drinking contaminated milk. So I will get off that soapbox here for a bit. Okay. Now, if the droplets are small enough to reach the alveolar space, so if they're about 5 to 10 microns, then the Mycobacterium tuberculosis cells will be encountered by alveolar macrophages. In a certain percentage of cases, the alveolar macrophages will kill the organism. In another percentage of cases, the alveolar macrophages will not be able to kill them, so the Mycobacterium tuberculosis will survive, and they survive inside the macrophages. And you talk about an organism with lots of tricks up its sleeve. This organism has more tricks for surviving in macrophages than Carter has pills. So in the lungs, the macrophage will produce various cytokines and chemokines. And for example, it will produce interleukin 1b, it'll produce interleukin 6, it'll produce interleukin 12, it'll produce tumor necrosis factor alpha. So these will summon a variety of cells like neutrophils. It'll attract lymphocytes. You'll also get some fibroblasts. And they will surround the infected macrophage. And this is from one of my slides. And they will wall off this organism and essentially tuck it away in a sphere, well, elliptical sphere-like nodule. And this is a classic granuloma because the inflammatory process is enriched for monocytes. The classic tuberculosis granuloma. And there's a picture of one of these on one of the slides that didn't reproduce very well here. But the thing to notice is that the monocytes are toward the inside, the lymphocytes are towards the outside, and then even further out here, you may have a population of fibroblasts. And in here, you have macrophages, neutrophils, dendritic cells, what have you. And that's essentially what you have here. That will control the bacterial replication because the organism is an aerobe for the most part. Now, if for years people thought that Mycobacterium tuberculosis was an obligate aerobe and that the formation of the granuloma prevented growth because the organism was cut off from air. That turns out not to be completely true. The reason for this is very simply that this organism grows slowly, very slowly. If you culture Mycobacterium tuberculosis, you're going to wait about 6 weeks for a culture to grow. So, is it growing aerobically? Is it growing anaerobically? If it's growing anaerobically and it's growing slower than it grows aerobically, it's going to be very hard to detect it. But it's clear that the organism is encased inside these granulomas and it's contained. And this is so-called primary tuberculosis. This takes place in the lung. Primary tuberculosis, that takes place in the lung. Now, that's if the infection is controlled. And I'd like to show you so here are some pictures of this organism growing. If this is in the microscope, you notice it has the serpentine grow through it. And notice this organism is acid-fast. So if you stain it with those acid-fast stains that we used in the laboratory, so we used the Neil Zinsser stain. That works very well. It will stain it quite beautifully. So this beautiful acid-fast staining, the organism has kind of a pink stain. That's with that Zeal-Nielsen stain, or the Faskinial stain, which I don't really like. But here's kind of the individual organism. Boy, the glare on that is bad. Let me shut the lights off the glare. Yeah, the glare's not quite so bad now. So you can see the pink organisms. And then if you look at the organism inside sputum, notice that the cells are growing inside the alveolar macrophages. They divide very successfully inside the alveolar macrophages. You can see them here. All right, now this characteristic lesion that's produced by the tubercle in the lung is going to generate something called a Ghon complex. And you can see a Ghon complex. Again, this is a slide from my PowerPoint. You can see this as this little piece of consolidation, and these can be stable in X-ray for years. So there's one over here. There's one over here that's pretty commonly in the hilar area, near the mediastinal area here. So it's usually near the hilar area, or they can be peripheral usually, but they can occur anywhere. But more often than not, they're hilar or peripheral. And again, these can be pretty stable for quite a long time. Within the complex, within that granuloma, you get something called caseous necrosis. It's called caseous necrosis because it looks like, caseous means cheese-like. the tissue kind of looks like cheese. Necrosis because it's dying due to ischemia. Anoxia, lack of oxygen. Now, sometimes these bone complexes will undergo scarring and calcification. So if they undergo scarring and calcification, then you have something that is called a Ruhnke complex. And very often, these things may not have any live cells inside. And they might, but they very often don't. I had a friend when I was a undergraduate at UC Davis. He'd been a missionary doctor, and he had several bone complexes. And so when he retired, he was watched very carefully, and he had to have a lung biopsy once. There was some suspicion that one of those bone complexes had gotten bigger. They were worried it might be a tumor. It was biopsied, and there was not a single viable Mycobacterium tuberculosis cell was inside that, and it turns out he didn't have cancer. So we were all praying very hard for Dr. Corby. But sometimes they do, sometimes they don't. And these Ruhnke complexes can be pretty easily seen on an X-ray. All right, so pretty much this is about where it ends for most people. Now, if the organism is not cleared by the innate immune system, then you've got a real problem on your hands. And let me just say, so the organism has in its cell wall, first of all, there's lots and lots of wax, lots of waxes, lots of lipids, things like that in the cell wall of Mycobacterium tuberculosis. It's a very, very, very hydrophobic cell wall. Here's again from one of my slides. So this is a gram-negative cell with lipopolysaccharide and outer membrane, thin peptidoglycan layer, and the plasma membrane. The tuberculosis cell wall has the plasma membrane, peptidoglycan, and then you have a layer of rabinogalactan here, and then you have this layer of mycolic acids. These are these branch chain fatty acids, and then you have the so-called trehalose dimycolate. Trehalose dimycolate is also known as cord factor. Now, why is cord factor important? First of all, cord factor is a potent inducer of granuloma formation. Also, cord factor tends to be toxic to white blood cells because it acts as a mitochondrial uncoupling agent. That is, it prevents ATP synthesis by the membranes of blood cells. So the white blood cells now become dependent upon glycolysis. Also, when the organism is phagocytized by the macrophage. So the organism now is within this phagosome, and this phagosome is meant to fuse with a lysosome. This organism has several strategies that prevent this fusion. So it lives very happily inside the phagosome and divides until it fills this whole cell and eventually kills it, or it divides slowly and then this thing can take it to any organ in the body. And herein lies the rub, or at least maybe one of the rubs. Some 5 to 10% of people who experience primary tuberculosis go straight away to the disseminated disease. This is sometimes called reactivation disease. Now, let me say, the first primary infection that you get very often can be completely asymptomatic. Some people may experience some chest pain. You may have a dry cough. It's not at all severe. You typically have no idea that you have this. But this organism slowly grows, slowly spreads, slowly rips your lungs to shreds, can spread to other organs, can cause a variety of different types of damage to other organs because they're carried there by the alveolar macrophages. Now, if you are immune to the organism, then typically your T helper cells will secrete interferon gamma. And interferon gamma signals to the macrophages, and the macrophages now are capable of killing the Mycobacterium tuberculosis. So that's why people who have immunity to this organism are able to properly deal with it, because they have T helper cells that provide cell-mediated immunity that help the macrophages give the organism the deep six. Okay, so sometimes these initial GON complexes, if you get a person who either gets an HIV infection or maybe they get malnutrition, or maybe just aging, the cells within the GON complexes can become reactivated and they can burst out. They can spread to one or both upper lobes of the lungs. Largely because the oxygenation is the greatest in these areas. The memory T cells will secrete cytokines, and you'll get you'll then get more areas of caseous necrosis. Over time, though, the lung is going to tend to cavitate. You're going to get holes in the lung, which will allow the bacteria then to disseminate through the lymphatics to other parts of the lung. That can cause bronchopneumonia. And then it can spread elsewhere. And if you have this dissemination of tuberculosis throughout the lungs, you have a condition called miliary tuberculosis. Miliary tuberculosis, because the X-ray will appear as though you have little grains of wheat. So miliary comes from the term for wheat in Latin, and here's essentially miliary tuberculosis. You can see you've got centers of infection all over the lung. This is a very sad condition. So dissemination, of course, it can cause meningitis, leading to headache, vomiting, seizures, and confusion. You get chronic back pain because the Mycobacterium tuberculosis can infect the vertebral column bones, causing kyphosis or cord compression, leading to chronic back pain, sometimes severe back pain. These bones can even break. You can get abscesses in the abdomen. The psoas muscle can be subject to abscesses. That is really painful. You get weight loss, fever, night sweats. You can have anorectal ulceration, arthritis if the cells get in a joint and cause septic arthritis. It can infect the urogenital tract, causing hematuria, dysuria, and infertility. You can have intestinal obstruction, mesenteric adenitis. It can also infect the adrenal glands, causing Addis disease. Pericardial effusion, causing cardiac tympani, and constrictive pericarditis, cranial nerve palsies. It's just, disseminated tuberculosis is a drag. It's just a full-on drag. All right, so diagnosis. Oh, incidentally, the infection of the lumbar vertebrae, that's called POTT disease. P-O-T-T. P-O-T-T. POTT disease, which is associated with TB of the vertebrae. POTT disease. Let's talk about diagnosis. Now, you can do a culture of sputum. Problem is trying to get the growth of tuberculosis on culture media. First of all, it's not going to grow terribly well on a lot of your media. So the medium that you're going to use, standard medium, is so-called Middlebrook. Middlebrook 7H12 medium is the standard medium. You have a mixture of antibiotics to prevent other things from growing. There are broth-based systems too. The thing is, if a person has tuberculosis and you want to start treating them, you need to know right away. So cultures, while they're done, just to confirm, usually while treatment has already started, you're usually not going to do a culture and wait for 6 weeks. No. So that is classically done, but it's not usually the mainstay. The biggie usually now is the so-called PPD. So this is the purified protein derivative, and it's a purified protein derivative intradermal skin test. You guys had to have this before you matriculated to the nursing program, and this is your tuberculin skin test. And this is looking for the presence of those T helper cells that are sensitized to the tuberculosis antigens. And if they're sensitized to it, they will attract macrophages, and you get a slight granuloma where this was introduced, and you get that reddish raised bump. That's your test. This is also called the Mantoux test, or simply just a TB test. You get a small localized reaction, usually 48 to 7 hours. So this is a delayed type hypersensitivity. It's not like immediate type hypersensitivity that you get in minutes. Nope, this is a matter of days. Now, a positive skin test does not mean you have active tuberculosis. It means you've been exposed to tuberculosis at one time. It does not distinguish between active and latent disease. Are there other tests that you can do? Well, first of all, there's a chest x-ray. So here, for example, is a chest x-ray of someone with fairly extensive tuberculosis that's causing respiratory failure. Here's a chest x-ray of another individual. This is recently acquired tuberculosis. You can already see the Ghosn complexes here that are forming. So a chest x-ray can distinguish usually between active and more dormant tuberculosis. You're also going to you're also going to look at symptoms. Now, the symptoms of active tuberculosis can be pretty general. The biggie is fever. That is the one that comes up all the time, virtually. Fever, and usually there'll be night sweats. There's usually loss, so there's a so-called cachexia. With active tuberculosis, if it's miliary tuberculosis, hemoptysis or coughing out blood, very common. You can identify the organism in usually a bronchopulmonary lavage. And if you get that, you can stain for the organism using an acid-fast stain. there are very good PCR tests, too, that will identify this organism, and you don't have to wait 6 weeks to identify this organism. All right, so you have a patient who has tuberculosis. How do you treat them? With tuberculosis, you always use a combination drug regime, always. You never treat tuberculosis with a monotherapy. You're asking for the rise of resistance. So to prevent that, you use a 4-drug combination. So there's 2 stages: intensive treatment and continuation treatment. You're going to use these 4 drugs here: rifampin, isoniazid, pyrazinamide, and ethambutol. We talked about these drugs in our section on antibiotics. I'm going to ask you to please review that so you know what these drugs affect. Remember the biggie about isoniazid? This is a common question on the NCLEX. This can cause peripheral neuropathy. And in order to quell that peripheral neuropathy, you tell the patient to take B6, vitamin B6 supplement. Hugely important question. I've seen that question on the NCLEX more than once. So you treat with this 4-drug combination for 2 months. That is your intensive treatment regimen. So this is called the RIPE regimen. And after you treat for 4 months, for about 2 months. So strictly speaking, 8 weeks. You then shift to continuation treatment with just rifampin and isoniazid. Now, some people cannot take pyrazinamide. Why not? Because of gout, or because of hepatotoxicity, their liver can't take it, or because of pregnancy. Because the drug is contraindicated during pregnancy. If that's the case, and you go to a 3-drug regimen, then instead of treating for 4 months with rifampin and isoniazid, you're going to extend that to 5 months or maybe even 6 months. Something to keep in mind. And there are different regimens to do this. You can do it daily, you can do it twice a week, 3 times a week. There's different regimens for it. And some clinicians prefer one over the other. If you have tuberculosis, more commonly than not, you get referred to a specialist who specializes in treating tuberculosis. Just saying. Not just to say that the average family practice clinician is not competent to prescribe these. More and more, these are being handled by specialists. Now, if this drug regimen does not work, then you might have multi-drug resistant tuberculosis. And now you have to look at a different regimen. And now essentially you have to go to a specialist who will prescribe something that is, and these are dictated by the European Respiratory Society, the Infectious Disease Society of America. We have a 5-drug regimen and an intensive phase that goes for 6 to 7 months, and then a continuation phase that goes from 15 to 21 months. And then if you have the extremely drug-resistant tuberculosis, then you have to go to a 5-drug intensive treatment for 5 to 7 months, and then an additional continuation treatment for 15 to 24 months, and this will usually also include injectable drugs besides oral drugs. And for these, you will definitely be referred to a infectious disease specialist. These are nothing to mess with. You'll tend to see these sorts of conditions in immigrants, particularly people who've come from the former Soviet Union, because MDR and XDR has ravaged the Russian prison system, because the Russian prison system has not done a very good job of monitoring if people take their medicine. So that's been a breeding ground for high-level drug resistance in the Russian prison system. Also in parts of China as well. So if you get someone who's an immigrant and they have a positive skin test, that might mean they have the BCG vaccine. That's another thing. The BCG is Bacillus of Calmette algorine, and this is a vaccination. So it's an attenuated strain of tuberculosis. They'll have a positive skin test. So this, if they haven't had this and they have tuberculosis, monitor them carefully. Also, people with tuberculosis, they have to take their medicine as prescribed. They must. So there are so-called monitored drug programs where social workers make sure they take their drugs. This is particularly the case with the homeless population. And if some of you do community health, this is going to be a big deal, monitoring people to make sure they take their medicine. Because this can spread like wildfire through homeless populations, and then it spreads through the social workers who represent them, the attorneys who represent them, the police officers who arrest them, the clinicians who treat them, blah, 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 blah. It just doesn't stay in the homeless population. So this is a big public health problem that you as nurses will be involved with helping out. All right, so that is the skinny on tuberculosis. Very complicated infection. And I hope that as clinicians, you will have the chance to show love and compassion to people with tuberculosis. Okay, let's do a little bit of cleanup on a few of these pneumonias. So influenza, which you will see constantly throughout your careers. So there's two types of influenza, influenza A, influenza B. Because this is a segmented virus, its genome inside the virus is found in RNA segments. These segments of negative strand RNA are surrounded by nucleic capsids, and you get the external glycoproteins that project from this, and these are the HN proteins. And the H and the N proteins are involved and these attach to the surface of the cell, and these are responsible for entry into the cell. And neutralizing antibodies made by the immune system will be made against these external glycoproteins. Now, the polymerase that replicates the RNA is subject to errors. So these portions of the genome undergo mutations. So this will be subject to amino acid variation. That's called antigenic drift. That's why you have, an H1, H2, H3, blah, 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 N1, N2, so on and so forth. That's due to antigenic drift. This organism, first of all, it's stable in bodies of water, fresh water, not salt water. So it can reservoir in waterfowl, so it can be passed to other birds, and it can also be passed to pigs. And in birds and in pigs, these viruses take segments. They can be infected with more than one type of influenza, and they can swap out some of these segments. And so you can get different types of hemagglutinin being swapped with different types of neuraminases. That's called antigenic shift. And that's due to the fact that this virus can also infect these other animal reservoirs. And then these can then come back and infect humans, and then the human will have a unusual influenza that the immune system's never seen before. Now, the type B is more stable, doesn't undergo mutations nearly as often as A. There's also a recently discovered type C influenza. It's the most stable of them all. And the amount that it plays, the role that it plays in human disease is pretty minor. So, most stable. C causes mild disease in children. Type B can affect both humans and pigs. And type A is the one that can also infect birds. So type A is the one that's people are most afraid of. Okay, antigenic shift, by the way, was responsible for the Spanish flu in that epidemic in 1918 that wiped out 3% of the world's entire population at the time. And 1918, the end of 1918 was a return, that was the end of World War I. On the 11th day of the 11th month, at the 11th hour, the armistice was signed, and then troops came back bringing the flu to other places, causing the very massive epidemic that started in 1917, but the second wave was actually more deadly. Okay, so with influenza, symptoms will start 1 to 4 days after infection. 1 to 4 days after infection. And you guys have seen these before. You get a fever, you get a runny nose, rhinitis, you have a sore throat, You have a cough, usually a dry cough. Typically, you get better a week. It may persist for 2 weeks. If there's complications, you'll get things like, first one, you get secondary bacterial infections with either Staph aureus or Streptococcus pneumoniae. You may have croup. You may have bronchiolitis. You may have acute viral otitis media. And you might even get pneumonia. Highest risk of complications, of course, are children under 6 months. And also pregnant women. And then adults that are over the age of 65. Also people with some sort of chronic medical condition, chronic heart or lung conditions. And in young children, you can get neurologic complications like encephalitis and then febrile seizures. And then important complication would be Reye syndrome. If the child has a flu, they're given aspirin, and then you get severe liver damage that will cause encephalitis due to high ammonia levels in the blood. So diagnosis, very good PCR test available for the flu. You can also do a rapid influenza diagnostic test, which can detect the flu from saliva or nasal secretions. Problem with these tests, they vary. They're fast, very fast, but they vary in reliability. So they each have their place. The PCR test is much more reliable. Much more reliable. You can grow it in culture, but not many places do that. This is a test that's more reliable. So treatment, and treatment is, if the treatment has to occur early for it to be effective, you have to start within 48 hours at the onset of symptoms. After that, the treatment is not effective. So Tamiflu, otherwise known as also Tamivir, that's your big go-to nowadays. This is also approved as a prophylactic. And this prevents the flu virus from binding to the surfaces of cells. An inhaled anti-flu drug is zanamivir, and that's a BID inhalation. Peramivir is available, but peramivir is only available IV, so that's good for inpatient treatment. So 600 mg treatment, for 5 days. This can really cause a bad set of upset stomach, so GI distress. And a new drug, baloxavir, which actually inhibits the influenza polymerase, is a new drug, does not cause the GI distress that oseltamivir causes. All pregnant women, it's recommended, CDC recommends you treat them. Oseltamivir has been found to be safe in pregnant women. Zanamivir 2, peramivir, I don't believe there's data on that. Baloxavir, there's definitely not data on that. It's just too new. And if your patient requires hospitalization or if they have severe disease, treatment is automatically recommended. Okay. Talk now briefly about Q fever. This is a zoonotic infection. It's caused by Coxiella burnetii. This is a weird little critter. So Coxiella burnetii, it's an obligate intracellular parasite. Structurally, it's gram-negative. It looks like a little pink rod under the microscope. This thing, however, can form endospores. So this, as far as I know, is the only gram-negative organism that can form endospores. So you won't be able to grow this in culture, at least on agar plates. So you usually get this when spores are blown downwind from animal farms, or if you come into close contact with livestock. So people at high risk include those people who work on farms, particularly cattle or slaughterhouse workers. They're at high risk as well. So the organism is engulfed by macrophages in the lung. However, in the case of Coxiella burnetii, you don't get phagosome lysosome fusion. So the organism survives inside the macrophages. And it does that because it secretes, it has a type 4 secretory system. It secretes effectors into the macrophage and tells it, hey, don't do that to me. I'm your friend. And it starts to replicate. So usually within 2 to 3 weeks after exposure, you get pretty nonspecific symptoms. You have a high fever, and you have chills, and sweating, you have a headache, fatigue. You also have myalgia, muscle aches. You have a cough. It's usually not productive. You may also have nauseating, vomiting, diarrhea. So not very specific symptoms. Importantly, you do not get a rash. No rash. Because the disease presents with nonspecific symptoms, it can be a little tricky to diagnose. The real tip-off is going to be contact with livestock and farms and things like that. Usually you get sick, you get over it. If there are complications, the organism can cause endocarditis. Not terribly common. It can also infect bone marrow, central nervous system, bone, heart, liver, and lungs. But it's not usually something you see very often. So there's good serology for it. When the organism is replicating in the macrophage, it makes so-called phase 2 antigens. There's a really good serological test for that. There's also good PCR tests, but you have to order them. There's also something called the vial Felix test. And if a blood sample is mixed with antigens from another bacterium, namely members of the genus Proteus, the blood will clump. And so there's some sort of cross-reactivity. That's a test you could do at the bedside easily. So treatment is typically doxycycline. And this should be old hat to 100 mg BID, usually for 14 days. And usually you want to do serology 3 to 6 months after treatment to confirm resolution, because chronic Q fever can lead to this endocarditis. Okay, last thing I want to talk about is Paragonimus. And the main species of Paragonimus is Westernan. Westermanni. This is a more common one. A less common one is Kelati. Kelatati, sorry. So this little critter has a very complicated life cycle. This comes from the CDC. The CDC website about Paragonimus. So it's shed into the feces. You shed a egg that is unembryonated. It develops, and then it hatches, and you get this ciliated mericidium that then infects a snail. And in the snail, it goes through several developmental stages. It becomes a sporocyst. The sporocyst then becomes a rhedia. And it actually goes through sexual development in the snail. And then in the snail, it will emerge as a so-called Sicariae. They emerge from the snail. These are motile. They will then infect usually crustaceans. So crab, crayfish, and usually when people get Paragonimus, it's because they've eaten uncooked crayfish, uncooked crab, something like that. And then when you ingest this, the Metacercariae insist, they exist in the GI tract, in the duodenum. Then they penetrate the intestinal wall into the peritoneal cavity. They then migrate through the abdominal wall and diaphragm into the lungs, and there they will encapsulate and insist and develop into adults. So these are liver flukes. These are trematodes. They can insist also in muscle or brain. That's really rare. Time from infection to oviposition is about 65 to 90 days. And the infection consists for years because you may not know you have them. And then pigs and dogs and other feline species can harbor Paragonimus as well. So Paragonimus patients will typically, they may be completely asymptomatic, or they may have a cough. As the metacercaria are migrating through the abdominal cavity, they may have abdominal pain. They may have some low-grade fever. And this is usually 2 to 15 days after infection. It can sometimes mimic tuberculosis because of the blood-tinged sputum you might get. Treatment, fortunately, is pretty straightforward. You treat with this stuff called praziquantel, which is very effective against the adult. And if you cough up a Paragonimus specimen, it will look something like this in the sputum. Yeah, that doesn't look normal, does it? So you treat with praziquantel, and you treat it in 3 divided doses, 1 day each, 75 mg per day, 75 mg per kilogram body weight per day for 3 days. Very effective. Or triclobendazole, probably not as well tolerated as praziquantel, but equally effective. 10 mg per kilogram body weight once or twice. And that is pretty much what I wanted to say about respiratory infections. Please read about fungal respiratory infections, histoplasmosis, coccidioidomycosis. Coccidioidomycosis is restricted to the Pacific Southwest. So California, Arizona, parts of Nevada, Mexico. Histoplasmosis, you get from caves, you get it from bat guano and bird dung and things like that. And then cryptococcosis, which causes meningitis, you get it from pigeon dung. Read about those, please, and that'll be it for respiratory infections.